Okay, I'm just going to give you a tiny bit of organisational background to set this in context as to why I'm speaking to you today. The National Council for Palliative Care is the umbrella charity for palliative and end-of-life care, and one of its key aims is influencing government policy, and hence the work that we've done that has just been described by Ruth. And we're also supporting all sectors who are involved in providing, commissioning or using services. And our aim is promoting equity and excellent quality of end-of-life care for all. As part of the National End-of-Life Care Strategy in 2008, the Department of Health asked us to set up a coalition, and it was the Dying Matters Coalition, to help support raising public awareness about talking about death and dying as a key strand of helping to improve end-of-life care, and I'll talk about that a bit more in a moment. I just want to, before I set the context for this, I just want to ask you, I'm talking to a predominantly professional audience of commissioners and health and care professionals. Could you raise your hands if you have thought about your own death and dying, not in a morbid way, but whether you've got any preferences for where you may like to die? That's most of you. Okay, what I'd like you to do now, just for 10 seconds each, is turn to your neighbour and just tell them how you will feel if you never get a chance for that to happen and you die in your local general hospital on a trolley in A&E or on a care of the elderly ward where you've been for 3 months waiting to get discharged, or you die at home when you actually wanted to be in a residential care home, whatever it might be. Just tell your neighbour how that will feel for you, because that sets the context of what I'm going to talk about. You've got sort of 10 seconds each just to exchange. Okay, if I could have your attention back again, please. I don't apologise for putting that in a personal context, because as health and care professionals, we have a duty of care to ourselves and our families, as well as to the people we look after. And we know, as the Minister spoke about this morning, that we're going to see a dramatic increase in our ageing population over the next 20 years. And this is going to have a profound impact on services. If we look at some data that was produced by Higginson and Gomez back about 4 years ago, if you look at the trajectory for the increasing death rates, we had a very good decrease in death rates in a period where we were improving infectious diseases and having lots of impact on the death rate. But now, because of our ageing population, we're going to see a 20% increase over the next 20 years. That means we either need 20% more capacity in our acute hospitals, or we need other care provision, and we need to make that other care provision happen. We had the Minister today talking, who this morning, if you were in the plenary session, said that he was not expecting to be a minister. And I think I put this slide in here because although our governments change and policies may change, people don't change, their needs don't change. We know that we have an ageing population living longer with multiple conditions, and we know that the dementia burden is going to be bigger and bigger, with nearly 1 million by the end of 2020. And as I've spoken, we're now 2 hours into the conference today, and across England, 120 people will have died in the 2 hours that we've been here. 1 a minute is the statistic. Of those, over half have probably died in our hospitals because they haven't necessarily had the option to die in their place of care. This is really important stuff. If we look at our hospitals, we know the statistics, and for those of you who are commissioners and who are looking at coming to sessions like this from a perspective of, yes, improving quality but also improving efficiency of care, we know that people dying in hospital, A, isn't what they want, and B, is not cost effective. The Minister described this morning, and I'm glad that my statistics are similar to his, that actually if we look at the beds occupied by older people, 40% of those in hospital will have dementia, and people in dementia stay in hospital longer. We've got to do something about it. And the dementia challenge that we have, we've got the issue of low diagnosis and professional confidence, but More importantly, or not more importantly, as equally as importantly, is the lack of public awareness and understanding that applies to both people living and dying with their dementia. These slides are going to be available for you after, so I'm not going to talk to this one in detail, but the challenges are manifold, and what I want to talk to you today is about that simple thing about talking about your wishes. This isn't about costly interventions of drugs, of costly interventions. This is about giving people the option of their conversations. We talk about this in terms of advanced care planning, and what we know with advanced care planning is that people living with dementia, although advanced care planning is a key facet of the end-of-life care strategy, if we don't plan for our deaths and what we want and what is important for people, then the likelihood of getting those needs met is very limited. But what we do find is that although people support, when we do surveys of the country, and we've done a couple of very big ones, people are very committed to the idea of doing their advanced care plans, but only 8% of the public have actually done an advanced care plan. And if I asked for a show of hands now, given the age profile of this audience, probably that would be similar here. There's very little research or evidence about advanced care planning in dementia. We assume, and I think it is a fair assumption, and maybe if I asked Kath, who spoke so eloquently earlier about Sheila, and whether Sheila had had the opportunity to describe to her family and to her carers what was important to her, I think probably the answer would have been no. But when we do advanced care planning with people dying of any condition, but particularly with a dementia diagnosis, we increase their feelings of autonomy, we give them more control, we give them more satisfaction. It improves their quality of care, reduces stress, and actually improves outcomes for the family if they know that they've managed to help someone achieve their wishes. It helps in bereavement. We also know that where there is no advanced care plan, that very often the next of kin are asked, but they tell us quite often they don't know. If you haven't had that conversation with someone close to you about what they want, how on earth can you then make a judgment for them and actually feel confident that you're helping them with what they might need? Carers find making proxy decisions difficult. I know from the many families that I've looked after that if you start talking about, do you think they would have wanted to be resuscitated? Do you think they would want to be admitted to hospital for antibiotics if they have a very severe chest infection? If you haven't thought and had those conversations, as difficult as they might be, it leaves me with a big burden making that decision on their behalf. And for someone living with dementia, as their capacity and communication decreases, it's much more important to have these conversations at an early stage when they're still quite well, maybe with mild memory loss, than it is later. NICE recommends ACP discussions take place, but it's not embedded in routine practice. There's an economic case for change. We've heard this morning from the Minister about the costs around the inappropriate admissions to hospital for many people in old age living with dementia, dying from their dementia. Many of the admissions from care homes could be prevented. I heard yesterday from a GP when I was doing some teaching who said the day before a very elderly gentleman, 94, who'd been looking after for 10 years, was admitted from his care home to hospital because no one had put in place a decision about what to do if he became acutely unwell. Actually, the GP said, I knew in my heart he wouldn't have wanted that. He was winding down, he wanted comfort care, but he ended up dying on a trolley in A&E. The GP was devastated. I'm sure the rest of the healthcare team were, and there are things we can do about this. But we only have a small window of opportunity in many people after they've had their dementia diagnosis. And Paul Burstow, the former Minister for Care, was very clear with us that decisions about end-of-life care have to be made while the person has capacity if we're going to give everyone the opportunity. But what are the barriers? The barriers for us are the societal reluctance to talk about death and dying, and to plan for the future. If I was to ask how many of you actually have a written plan that you've shared with your relatives, and I'm not going to do that now, but it's probably less than those of you who've thought about where you want to die. We also know that clinician confidence, be that GP, nurse, social worker, support worker, can be quite low. We don't want to make things any more difficult. We don't want to upset them at a very difficult time. And also there's a fear of acceptability. Will patients and carers be angry? Will they make a complaint? What am I doing? I'm a long way off dying. I've just got this new diagnosis that I've been living with for a couple of months of having dementia, and suddenly someone's talking about when I die. We have lots of inhibitions and fears ourselves as practitioners. We also often like to pass the buck. Let the memory clinic consultant do it because that's their bag, or let's let the community nurse or the mental health team do that. What we find, if we did a national survey back in 2009 and we asked people in the public, who would you talk to after your loved one most about what's important about your death and dying? And they said, my GP. So first off, obviously, their close family member. Second was their GP. We then asked GPs, particularly around dementia, did they feel they had sufficient basic and post-qualification training around having conversations and diagnosing and managing dementia? Sadly, 63% didn't. I'm hoping that with the Dementia Challenge and all the emphasis on dementia, that is changing. But 35% of GPs in the survey had never initiated an end-of-life care conversation with one of their patients. That's not an unusual figure. We go to care homes in the work that I do, and many of the care homes will say, no, we don't have a formal process for when people are admitted to our care home for talking about what their future needs might be. And very importantly, a lot of GPs, when they've been surveyed, feel they have too little time to spend with people in dementia, and these conversations don't take place in a 5-minute consultation, they're part of a process. Now, what I'm talking about today is focused on GPs because as a core family constant of care, that's really important, but it's also applicable to the wider healthcare team. And what can we do? And the word I want you to go away with today, if you remember nothing else apart from my pink suit, is give people an opportunity to talk. If you're commissioners, are you commissioning services where your expectation is that people will be given an opportunity to talk and have their wishes recorded? If you look at the quotes here, they're very powerful. Very positive one of someone saying, we were advised to get a power of attorney. This was coming out of a memory clinic research of having training in having conversations with people about advanced care planning. They said, as a result, we took out lasting power of attorney, we contacted the DVLA, we downsized and moved nearer the children. It was really empowering. And then we have a case where a relative, after someone has died of their Alzheimer's, saying, I didn't know what Alzheimer's was going to do to him. His speech and understanding went. I was left with no idea of what he would have wanted for his funeral, how he would have liked to be remembered. This is really important stuff. So how can we do it? I don't want just to sort of give you the problems and not leave you with any ideas for solutions. We believe at National Council that one of the keys to this, yes, you need the processes and the paperwork and the registers and the initiatives that have been happening over the last while, but actually you need confidence-boosting interventions with health and care professionals. We've come up with some low-cost, short training sessions using DVD materials that have been produced by people living with dementia and their families and GPs, and then we translate that into workshops whereby people have an opportunity for doing skills practice in small groups and really share experiences of how they can initiate these conversations and try new ways. We liken it to having a tool belt as a practitioner. If you imagine me on my building site with my tool belt and different types of tools I might need, in our tool belt that we give clinicians in these sessions, they've got different phrases that they can use, different ways of introducing the topic, different approaches to give that confidence that yes, they've got really good communication skills, but they need to be applied in this certain way. And what we found is that, I've got a slide here, just showing that in the pilot that we did, which was with over 100 GPs, there was marked change in confidence from attending these training workshops. But we didn't just leave it at, do you feel more confident? We actually followed up with a 3-month audit to see if practice had changed. And yes, practice is changing by doing these interventions around having end-of-life care conversations. Now, this particular pilot was for general end-of-life care, not the dementia-specific training. This was having conversations with anyone dying from COPD or cancer or general old age. What we're doing now is piloting in 3 CCGs in the south, this training specifically geared to people living with and dying with their dementia. But it is acceptable. You might be thinking, well, it's all very well as professionals, we think this is a good idea, but is it acceptable? There's a really good paper published by Professor Banerjee and colleagues around a qualitative evaluation of advanced care planning in people with dementia at an early memory clinic. They took memory services and they trained up staff at the diagnostic or mild dementia stage. They trained them with both a tool around ACP that gave them a framework for the discussions and trained them in the confidence building to actually have the conversations. And then what they did was they followed 20 patients and 8 carers through this process, and then they evaluated qualitatively through in-depth interviews what the outcome was. Thankfully, it was incredibly positive. Patients and carers almost unanimously found ACP a very positive intervention. It allowed thinking and planning for the future. It enabled them to make their wishes known to their family and people important who'll be making decisions for them. And it resulted in less worry about the future and feelings of relief. Sometimes the feelings of the unknown in dementia care, the unknown of the journey, are so overwhelming that if someone can actually sit down and say, in my experience, this might be what happens. Are there things that are important to you that you would like at this point? It's empowering is the word that we've used earlier. But it's only empowering if it's actually shared with health and care teams. And I just want to put in a plug for end-of-life care registers. They do make a difference. The evidence is there. We know that out-of-hours care is actually 75% of the care time. And if people are identified as potentially in the last few months of their life and they are put on an end-of-life care register that is held by the GP practice that is the GP practice that's looking after them, and then the care home or the home, wherever they are, their place of residence, that then triggers regular review. This results in people actually getting their needs much more met. 80% of patients who have been on the end-of-life care registers in the national pilots have died in place of their choice. You know, that's a significant figure, but obviously you have to ask people, can you share that information and what they want for it to be known? Now, along with the training interventions, there are also resources out there, and from a Dying Matters perspective, we've done quite a bit of work working with communities to develop messages to raise the public awareness about these issues. There's quite a lot of publicity now about dementia for the general public, which is really good, but often that doesn't talk about dying of your dementia. It talks about good care while you're alive, which is really important, but it doesn't talk about the end stages. And actually, for some people, it can be a surprise that people can die of their dementia. And people can get afraid of talking about it. I won't embarrass you by asking for another show of hands about who's ever talked about sex in their lives, but I imagine there'll be 100%, either when you were at school or as an adult or with friends. We tend to, as a society, we talk about sex a bit. Just by talking about sex, we don't get pregnant. The corollary of that is if we talk about death and dying, we don't hasten our own death. But there is a fear in the general public, actually in some clinicians and professionals as well, but if we talk about it, somehow we hasten it. We need to get being more public about, yes, the early stages of dementia, the great care that you can have, that you can anticipate, but also about the end stages as well. So there are resources that are on the Dying Matters website that you can use both as commissioners and as carers. Talked about the training DVDs, but we've also produced, and there are other organisations, this isn't just a plug for Dying Matters, there are other organisations that have good materials out there. Look for them as commissioners, commission them as providers, get them in, because, for example, our booklets on having difficult conversations with people with dementia actually uses phrases and has been developed by people with dementia and their families. It's talk to us like this is our experience, this really helps. We've also produced a booklet around dealing with pain and distress for people with advanced dementia. And again, that's very user-friendly. It's aimed at both families as well as carers. It's not highfalutin academic. There's academic research underpinning it, but it's produced in a way that actually says, this is what you can do. This is how you can think differently about this. It really does make a difference for people living with dementia. I was going to show a clip of one of our bereaved relatives who's worked with us, whose wife died of dementia. in these conferences, that can be a little bit scary sometimes in terms of would the technology work or not. So I decided not to show it, but I just want to read you 2 quotes. They're very short, so please bear with me. This is Brian talking about his experience with Jayne, and he says, "I think if someone had simply said to us, 'Have you thought about the last weeks of life?' A very simple question like that, it would have done so much for us." And talking to him in more depth about that, it was about the opportunity to have a shared discussion and plan, rather than just let it happen and then it be too late to actually find out what Jayne really wanted. One of the GPs that we've worked closely with speaks very eloquently on our DVD and says, "What's really important is to get to know the person. If you understand what's important, their fears around death, then we'll be able to treat them better." Is it not our duty of care within the care home, if you're here from the care home sector, or as a nurse specialist, or as a community nurse, or from a GP perspective, is it not our duty of care to understand what people are fearing and thinking, to be able to support as a multi-professional team dealing with those concerns? There's a few things that you can do. We're a bit like good Girl Guides and Boy Scouts. We think be prepared is a motto that we should all have. And that's about, my challenge to you today is, if you're a commissioner here, or if you're a provider, ensure that you've got training that increases confidence, not just academic skills and knowledge, but actually practical skills-based sessions that are safe, that allow people to practice ways of doing it, that uses real patient stories, maybe uses interactive DVDs like I've described, and actually support increasing their confidence, because only with confidence will people change their practice. I can have all the knowledge in the world, but if I haven't got the opportunity to practice putting that in place, I might not do anything differently. Then secondly, lead by example. Think about your end of life and your preferences, write them down, make your will, tell your loved ones, and then get on with living. And get other people talking about their wishes earlier on. Talk about it in your family, in your communities, and in your workplace. It doesn't have to be depressing. You can do it with humour. I stood during Dying Matters Week, our big public awareness week, in a forecourt of Tesco's with a lady dying of COPD. She sat there in her wheelchair with oxygen and with a big beaming smile saying to people, "Come and talk to us about dying, it's really important." And there was a bit of, "Oh, not sure about this," but she does it with humour, she does it with sensitivity, and she says it's really important. Get your organisation involved in the Dying Matters Coalition. You can sign up as individuals or as organisations. There's a wealth of resources there for you, but also it's part of the growing body. We've got over 30,000 members, so if you join the coalition, you'll be part of a movement that's saying it's okay to talk about death and dying, and if we do it, we will improve outcomes for people. I just want to leave you with a thought. And again, this isn't meant to be a depressing thought, but a very encouraging and inspiring thought. Whoops, I beg your pardon. There are no second chances when it comes to dying. How the memory of people dies lives on with their families and with their carers. That GP who shared his story yesterday is really concerned that he'd failed that family and that patient. Obviously, that family will be very distressed as well. We have one chance to get it right. Yes, we need the processes. Yes, we need the joint commissioning and the resources. But a simple intervention around improving confidence for health and care workers to have the conversations can make one of the biggest differences too. Because we've shown with the very detailed work that's been done in the end-of-life care pilots that if we know what people want, then the likelihood of achieving it is significantly greater than just leaving it to chance. Thank you very much.
Thank you very much. That's a really important message for all of us. We've got about 5 minutes for questions, so has anybody got anything to ask Jayne? Yes, gentleman in the middle. Could you say who you are, please, with the mic?
Thank you. I'm Michael. I'm from the College of Social Work, and one of the big things that we're trying to sort of develop social work as a profession is by sort of seeing it beyond that kind of immediate responding to care needs, so dressing and washing and other things like that, and taking it beyond that and sort of thinking about what a social worker's training involves. And I'd say that empathy and that kind of understanding is a kind of core facet of their learning and their development. And you've talked about GPs and their role in bringing this up as a subject, but I also think that like social workers have a crucial role to play in not only necessarily having the conversation themselves, but reaching out to the family, reaching out to the wider network, the person who has complex needs with like dementia, and giving them the confidence to talk about death. And I'm just wondering what you've done to sort of engage with social work as a profession or that kind of care side of it to sort of broaden this.
Sure, that's really important. And what I didn't mention, because obviously in a short talk you don't have time to mention all the work, but we've started work with some of the national bodies, but also with particular care home charities. So we've done work with the Shaw Foundation, where we've had groups of social workers and care workers, and absolutely, this is not for just GPs. As I said in one of my slides earlier, it's too easy to say it's somebody else's job. It's not just for dementia specialist nurses to be doing. It's not just for social workers to be doing. It's a team approach. And I think what's key, and why I guess the GP is, I think in our minds, one of the starting points, but certainly not the finish point for this work, I think is because they are the hub for the end-of-life care registers. But actually, even if the GP doesn't have the conversation, if they've identified and put a person who's living in a care home or who's on their community, on their practice register, on an end-of-life care register, then they can talk as a team. Who's the most appropriate person to be having this conversation? And obviously, when it comes to someone being diagnosed with dementia at an early stage, it may not be appropriate at that stage for an end-of-life care register, but again, the practice can be the hub for saying, we've got this person with a new diagnosis, they've got this social worker, they've got this key care worker, would you like to start those conversations? And then we'll come back as a practice and discuss how we can take those forward. Because they're also not just one-off conversations. They take time to sow the seed, to allow people time to think about it, discuss as a family, come back, do the documentation. So it's a process, and that can be the multi-professional team. But thanks for giving the opportunity for expanding that beyond GPs. Thank you.
Thank you. Anybody else with any questions? Yes, gentlemen.
My name is William, a senior carer in a residential dementia care home. I'm really intrigued about what you said, but one thing working in a residential dementia care home is that many people move into dementia residential care home in advanced stages of dementia and also with capacity reduced. So based on the information you're giving, it's very good, but how can we get around it, get information from the resident's perspective rather than next of kin's perspective about how they wish to die?
I mean, you've just hit the nail on the head as what the problem is if the discussions aren't had early on, as Paul Burstow said, in the dementia diagnosis. I think if an advanced care plan and these discussions haven't been had with the person before they arrive in the residential care home setting, and they have then lost capacity to be involved in those sorts of discussions, then there is no way of actually asking them if those conversations haven't happened. One of the things that can be important is to get a perspective of next of kin and family members, so it's not one person's particular agenda, because I wouldn't like resuscitation because I know the statistics, and it's not like it looks like on Holby City, so thank you, don't resuscitate me if I have an end-stage long-term condition, but that might be very different to someone else in my family who has a different perspective. So to get a family perspective may be an important way of doing that. But the key message for this, as a residential care home, why don't you initiate the conversations with the GPs that support your care home to say, how are you doing the advanced care planning? Can we be involved in supporting you as we're specialists in this care? And actually start that dialogue to say it would help us so much if people came with their care plans, their future needs considered.
Thank you. And there's a gentleman next to you, and then a lady over the other side, and that will be it, I'm afraid.
Jeff Parsons. Thank you again for giving insight to this. Could I ask, to what extent have you been involved with solicitors and possibly CAB giving advice on some of these matters?
As an organisation, we certainly have worked with some legal charities who are starting to provide advice for people around lasting power of attorney and making wills. As an umbrella charity, there are quite a lot of solicitors and legal firms who sign up to Dying Matters because they believe it's important from an ethical and a stance that's much more than an economic one. And again, that's very important that solicitors have the knowledge and the skills to have these sensitive conversations as well, but I think it's an area we may need to expand and do some more work in. Thank you.
Thank you. And the last question, lady there.
Hi, my name is Hilary Woodhead. I work with Dementia Pathfinders, which is a community interest company. I was just interested in the 3 CCGs that have signed up to the pilot, the Dementia Specialist Workshops in End of Life. Could you say a little bit about who they are and how to kind of get involved in that if people are working locally?
Yes, indeed. The first is North Hampshire. These is monies we put in a bid with the CCGs when there was some Dementia Challenge monies in NHS South last year. So we're working with Northants CCG. That's where we've started the first pilot. And then Kent Medway Sussex CCGs, we're at the stages of, we have the funding for that. We're just developing what it's going to look like for them to fit in with other initiatives. And the third is Dorset CCG. And again, we're at the early stages of, we have the funding for it, and we're looking to make sure that it fits in with other education providers around dementia. And we are wanting to do the delivery of it in association with other organisations, so steering groups which include Alzheimer's Society and others. So do talk to me afterwards if you want some more information. Thank you.
Thank you very much. We need to leave it there so that people can get to other sessions if they want to. Thank you again. And can you, if you're going to move on, can you do so quickly and remember to take all your papers with you? And if you didn't scan in when you came in, make sure you scan in when you